Great evening to all of you. Hope you all are doing well. I, on behalf of Society of Indian Physiotherapists and my founder members, welcome Susan Blum for this webinar. She is a pediatric therapist with experience of 45 years. She treats adults with special needs and children with cerebral palsy. She has some work with women's health. She graduated from the University of Vermont. She has many professional experiences in different therapies, to name a few: neurodevelopmental therapy, sensory integration, dry needling, Maitland, PNF, MFR, and many more. She owns a private practice, and she was the one with her mentor in 2007 actually discovered what we're going to listen from her today: total motion release. And that's for tots to teens with children. We are going to listen with CP. So without further ado, let us understand her insight into the potential behind understanding this toolbox: total motion release, tots and teens. We welcome you, Susan. It's all yours now.
Thank you. I'm so thrilled. So good evening. This little boy that you see here was the inspiration for TMR, for TMRtots. So I will tell you a little bit about him along the way. But I was working for 33 years using the same traditional concepts that you all are doing. And we hit a wall. I did not know what to do with him. I had exhausted everything that I had studied. And I'm a continuing education addict. Even though I am working 45 years, I go to numerous courses throughout the year. So I just did not know what else to do. And I need to reduce this so you can see the whole screen there. So I contacted the gentleman who developed the original TMR and asked him if this would help my children. And he said no one was using it for children, but I took the class. This little boy, Lucian, immediately started to have some breakthroughs. And a year later, he was walking. And so I'll share his story along the way. Okay. So we also use the Icf model as the center of everything. And the center of the Icf model being the patient or the child, it's what do you want to be able to do? What is your goal? What do you want to achieve? Not what I as a therapist think that needs to be fixed. Nobody needs to be fixed. I don't look at the child as broken. I look at the child as a person that just has some other things that they want to be able to participate in, and how can I help them do that better? And so the questions we ask is, how can we engage the child and family? How do we tap into their joy and find the thing that they want to participate in so that we can structure the therapy to support that? And what can we do therapeutically to build into their daily routines so that when they leave us, they're continuing to improve? And looking at them, and like a boy like Lucian, what could be holding them back? So as a therapist, we set the stage. Someone comes into their clinic, or I did birth to 3 early intervention for years. And I went into the homes, and I would be setting the stage for the therapy. I dialogue with the parent. What do they want to do? What are their concerns today? What are they hoping to achieve? How can I help them? We set up the toys that interest the child, eliminate the distractions, ask them if they can turn off the television set, choose the appropriate seating or whatever for optimal position, to find a little chair or a bench if they need to be sitting up. But then, besides setting the stage with the physical parts of their environment, we ask, what if their alignment is dysfunctional? What if he's struggling to sit or to stand, to do these activities? And what if their position is such that the trunk is rotated to the side and he can't access his left arm and he wants to do something with his arms? So how do we look at that? And so we have a 10-step protocol in TMR, which is essentially the toolbox. It's the way that we organize our thoughts, and this system, using your current techniques, which is the same as my pre-TMR techniques, the first 33 years, are targeted based on the findings of the first few minutes of each session, where we identify those blocks in mobility or alignment to minimize the struggle so that they can sit up or stand with more ease, and then we can focus on what they actually want to do. So every session that I see a child has a release, organize, and activate component. The release is to the getting ready work, the preparatory work to get improved alignment. The organize is providing some sensory input, which helps the child recognize the improved alignment. And then the activate is the participation, the activities that the child enjoys, which will reinforce and build on what they know, build on what they can do. Every session follows the ICF model, and every session is based on tapping into their joy to work on participation in a daily routine when they leave. And so if we look at the ICF model, the activities and participation in facilitating function are primary in terms of what they're interested in. But what we do with TMR is at the beginning of each session, we take a step back and we look at what is structurally blocked. And so we get that balanced so we can set the stage better and proceed to the activation phase. So I'm just going to give you a couple of examples of blocks in a session. This young lady came in and I said, what is your challenge? How can I help you? And if you look at how she's standing, she would only balance on one foot very well. She can't dance with her friends. All of her weight is on the left foot. Her pelvis is shifted way over to the right. Why is that so? And so I did my little assessment of the mobility, the first 2 or 3 minutes, and discovered that she was not elongating on the left side and her pelvis was shifted to the right, that she did not have the mobility to shift her pelvis to the left. She was stuck. She was blocked. So I said to her, what do you like to do? She said, I've been doing therapy my whole life. I hate therapy. I don't want to do exercises. And I said, that's okay. We're going to do what you like to do, which is to dance. And so I assessed and I saw that I could bring her pelvis further over to the right, what we call the direction of ease. And that in shortening her left side, it loosened her left side. We went to the motions that she enjoyed, which are the therapeutic motions. And by having her actually raise her right arm up, that indirectly shortened and released the left side. And I'll explain how that works as we proceed. But I'm just showing you, we looked at what she liked to do and we matched it with a therapeutic motion. And so we tap into their joy and we design the activity based on what they want to do that can simultaneously remove the blocks. We're doing a modified counterstrain motion by shortening to release. And then when she goes home after the session, she can enjoy doing a targeted therapeutic dance motion that is based on our assessment and our treatment to continue after the fact. So at the end of the session, having done that with me, then she has more mobility and, whoops, the cover over eyes, I need to fix that. You see, she has better alignment. So we videoed the improved gait and balance. She's got more weight on her right foot. Her speed increased, all objective things that we can measure. So that's pre-session, pre-treatment, post-treatment. In the meantime, we have instructed her and she has taught back how she's going to continue at home. And so that's the empowerment piece of TMR, that the parents or the caregivers or the older child is able to show us how they're going to incorporate it in their daily routine. And with the frequency and repetition of doing it day after day throughout the day, however they choose, it is all their choice. It gives them the opportunity to improve often even better than they were at the end of the previous session. I had a time a number of years ago when unfortunately my brother was terminally ill and I had to take off to take care of him. And I had to leave and cancel my clients for many weeks. And at the end of that time, they were better. They were all better than when I had left because they were participating with the activities that we had structured for their daily routine. So the improvement lasts, and it's often better than at the end of the previous session. So in the follow-up, she says, I can balance better on my foot and dance with my friends. I can walk further and faster. She improved even better. And I should correct that. It was her right foot. I think all the weight was on the left foot. Okay, anyhow. And also, I measured her objective measurement that there was better elongation and weight bearing than post-test in the last visit. And so the plan was then for this visit was to retest those and see what blocks were remaining to fine tune her balance and then video the improved dance. So this is what you're already doing, but it's precisely targeted based on the assessment that identifies the blocks. And so the optimal mobility is the prerequisite for easier motor learning. Okay, we remove the block first, and then we can go and work on the function. If we're trying to set up a tent and some of the ropes are too long and some are too short, we can't get the alignment that we need. And so short muscles and long muscles are weak muscles. When we get the alignment balance before we begin, we have the muscles at the optimal length to be able to function and learn better. So we're unlocking the potential. This young man was not seen by me. He was seen by someone that attended my class Monday morning after the class. Obviously, he has some significant challenges. Couldn't get comfortable, to rest, and in danger of having skin breakdown and the bony prominences, etc. And can't really do anything functionally to enjoy with his hands. She identified the blocks, released them by having him move into comfortable positions, similar to the dance, but within the range of what he was able to do, which was mostly active assisted, mostly assisted, guiding him into to more comfort. And here he is post-treatment, right afterwards, within the same session. And now he can we can look at what can he do, what can he enjoy, that is to introduce something into his hands that's pleasurable. But also we can measure his alignment, because one of our functional outcomes is the child more comfortable to rest? So we precisely measure the improved objective functional changes that are limited by the blocks, whether or not it is the ability to transfer to the toilet, and get positions of comfort like that child. How long can they sit up in class, in school, before they get tired? How many steps that they can play on the playground? And can they rotate to color left and right equally, or are they just stuck in one? Is their mid-range off balance? And something with social participation like dancing or swimming. Okay, so setting the stage, before we ask the child to move, we do the getting ready work of removing the block mobility to get the balanced postural foundation. And we have a decision tree going step by step with that. And my trainings I have level 1 and level 2, but level 1 is to do what I'm saying. Level 2, we use the same ideas that you're using with the concepts in NDT, et cetera, but we're tweaking their motor control based on their strengths, identifying their strengths and building further on their strengths. And I'll show you an example of that later. So what's the history, as Asha kindly explained? 33 years of experience, primarily pediatrics, before I did TMR. I had the NDT and the ICF model with foundation for my practice. And my focus was natural environments. How can I empower the parents and caregivers? Identifying what inspires and motivates the child to move, and finding activities and trying to and participation that can build on their available strengths. What were my challenges? We get plateaus in achievement. That the range improvements with the stretching and so forth were not lasting, and so we had short muscles. I have never wanted to stretch children because I never wanted to do anything painful. And we know that bursts of short-term stretching on the gastrocs are worthless. That's been clearly published. And so why do stretching? And so I've told the child there's no pain, everything is comfortable when you see Miss Susan. When they had the poor foundation, we'd have over-lengthened muscles. If they were in a kyphosis, the back muscles were weak. And so the children were struggling when they were off balance. And how do we address that? How to better address these points? Because what is important? A vertical posture is necessary to set the stage for motor control. We know children with CP have sensory deficits. And so I needed to include body awareness with proprioceptive input to reinforce my therapy. So after I did some therapy, I would do lots of bouncing on the ball or something fun to help them know where their body was in space. We know that neuroplasticity, from Jeffrey Klein's work, you have to do 15,000 repetitions to build maps, so somatosensory maps. So we had to include parent education and build it into the daily routine. We're not going to get 15,000 repetitions in seeing somebody for an hour in the clinic. It has to be part of their life. And then we had the issue of telehealth, especially now with COVID. Previously, since I have moved across the country, I stay in touch with clients. I have licenses in multiple states, so I'm able to do telehealth to work with the parents between sessions, and now do sessions on telehealth. But how to best address these points? So what was the turning point? The turning point was in 2007. I had a child turning 2 years old with profound hypotonia, massive limitations in range of motion. He was sacral sitting and kyphosis, hips and knees flexed. And as a result of this horrific posture, he also had, he was side bent, and which gave him a torticollis. I don't believe he had torticollis from birth. He developed a torticollis from this horrific posture. He didn't know he had a left arm, and he had severe respiratory and GI issues. Other than that, everything was great, right? I worked with him for 15 months, and he still couldn't roll or sit. I took the training to help him, and over the next year, that's the little boy you saw, progressed to full range of motion throughout his body and independent walking. What was the difference? We got the balanced foundation, and what we do in each session is provide enough input to help them feel their corrected alignment, some sensory input. Those are the pink boxes. And then we determine what we need to facilitate. Some of the children, we just set them up and we figure out what they can do that will reinforce and help them build on their participation. And that's the blue arrow. We don't really need to do much in terms of what you would think would be traditional hands-on therapy. It's more, as I did with the girl that was dancing, here's how you can move your body, and working with her like kind of hand over hand until she understood that. Some of our children more involved, we may need to do more facilitation. And some of our children that we get later on have developed incorrect compensatory mapping, and we have to do more facilitation to override and cancel that out so that they learn to do something more efficiently. Example would be a child that scoots on their bottom to get from point A to point B, and then we get rid of the block that's preventing them from learning how to crawl, but they're already kind of hardwired to scoot, and we could need to maybe do some hands-on to help them see that it's fun to crawl, okay? But this is all, again, what you're already doing, but it's just targeted. So this is my buddy Lucian. At 22 months, he couldn't sit or crawl or anything. His xiphoid almost touched his pubis because he was so weak. In order to sleep and to breathe, they had him in a reclined, like a hammock chair things, which are now illegal because they can't even sell them because they're dangerous. But he was so tight, and he couldn't sleep lying down. Here he is trying to crawl. This is after we had done therapy for 2 months doing TMR. So he's actually improved here, but you see he doesn't use his left arm, and he's so weak, and he drags his leg. He worked with Daddy by doing piggy toes and playing things. At 28 months, you see how his hamstring length, apparent hamstring contractures, have improved with the improved mobility throughout his trunk. And here he is doing targeted activities with me, playing and going into directions of ease. And here he is a year later, total year. And look at the beautiful length he has here and the active control, okay? He still has profound hypertonia, but we're having fun. And here he is just a short time later. Mother says he can walk now. He's taken his steps over the weekend. And now at 36 months, here he is on a hill. We're going down the hill walking, the same child, okay? So 14 months of treatment with TMR, and there's the progression. And at 40 months, he was independent on steps and running. So what took him from having the severe tightness, the sacrum almost horizontal, playing with Daddy with the legs coming up 2 months later. And then here at 6 months along the way, the feet, the legs coming up that high. We have a published paper on hamstring, apparent hamstring tightness improving with the TMR. So we look at his sacrum and how it's blocked. Why can't he sit up and learn to play and do the activities that he would like to do and progress him? Because his sacrum was blocked with the tightness from his xiphoid to his pubis. We removed the block, and here a few months later, he can sit up tall. So the turning point was TMR. Learning TMR from Tom Delonzo Baker gave me an organized system to identify and treat the key limitations that had been blocking access to optimal alignment, which then created a balanced foundation, and I could get even better, greater control with my NDT skills. Do you ever wonder where to start? You see a child come in and you see multiple issues. What took him from the upper left to the lower right picture at the beginning of the session? 2 to 3 minute test to identify his blocks, 15 minutes treatment with fun shortening activities, and then post-test identify the new access to glutes and abs that were weak and see what could we do to reinforce his new alignment. And so the balance of the session was to work on participation, explore what targeted activities will him use the newly discovered posture and develop control in the previously over-lengthened muscles that he could not contract because of the short, tight ones. With the 3 steps are release, organize, activate. Release is the first few minutes, and then of testing to find the blocks, treating the blocks, organizes the sensory input, jump up and down a little bit to feel your new alignment, and then activate. What activities can we do? They're going to use that new control that they can access. Why do we focus on alignment first? Because it impacts all the systems. That little boy lying on his back that was all flexed and twisted, it's affecting his digestion, his circulation, and his distal motor control, his hand control. And when there's compression in the trunk from side bending and twisting, besides the fact that the circulation isn't working well, the child may be constipated or have reflux. And they may struggle to sit up and be fatigued quicker. So they may have apparent limitations in their cognition, which may not be present or may be worse from trying to sit and attend when they're putting all of their energy into alignment. And so in school, if you had to sit in school on one buttock, twisted to the left and side bent to the left, and then to pay attention to your teacher and to be able to write, your life is a struggle. We're taking that struggle away. And so we look at what's over lengthened, we target, we shorten it, and we target it to get the alignment. So, and we look at how the child is off balance in all planes. So there are a number of other TMR motions too. They each identify commonly restricted areas of asymmetry. We put tape on the child to illustrate the restriction. The tape illustrates what does not move. So this bunny is shot, it has the hip near the armpit, has a limitation in elongation on the left side, similar to this child who is side bent to the left. And so the objective of TMR is to remove that tape. Imagine if you cut your palm and you put a Band-Aid on your palm, you put a bandage, a plaster, whatever, however you call it, and then you repeatedly flex your fingers. The Band-Aid falls off. That is the objective. We also have a diagonal bias, which is a limitation in rotation, and I'll explain that. how that works in a minute. So the turning point was I discovered with doing the TMR that children improved faster, achieved higher milestones, enjoyed therapy. We did targeted challenges for their participation. We focused the facilitation with the systematic application, which is what they could now access, what they could not previously access. It was more targeted. The parents understood and could manage between the sessions. The home program from TMR blended into the daily routines, and we got, with this new available range, it was fertile ground for development of higher level motor control, what I call uncharted territory, a discovery zone. So imagine this, if you sit and try this right now, sit and turn your chest to the left, okay? And you see your left arm goes back, and you have a limited access to your left arm when your mid-range of your sternum is to the left. That would occur with limited right thoracic rotation. If you lean forward with a kyphosis, you can't fully access your deep postural muscles, and you may fatigue or not be able to reach up overhead to toss a ball. And the glutes in a child with the pelvis retracted, if you stand up and you pull one hip back, it's hard to do a pelvic tilt. A child with diplegia, when we straightened out his pelvis, could better access his glutes and his gait improved. And so common imbalances are that we see in the children with CP are flexion in the trunk, left side bend, left diaphragm rotation, the thoracic diaphragm, and right pelvis rotation. And so if you try that yourself, you're going to stand up, you're going to lean forward, you're going to lean to the left, you're going to turn your sternum to the left and turn your pelvis to the right, and see what happens with the rest of your body, how that side bend to the left can cause abduction issues in the hips. It can give you a torticollis as well. That's what happened to my friend Lucian. We look at this and we have things that are shortened and over lengthened, and we need the balance. Okay, so if you tuck your shirt in that position, you tuck your shirt in on the left and it holds you that way. You tuck your shirt in the front now, and you hold you that way. If you stand with your shirt tucked in the front and your shirt tucked in on the side and try to catch a ball, and your arm, you see it's hard to raise your right arm up, and your arms are not in mid-range in order to catch the ball. And in that position, try to take a step forward. I'm sorry, I'm going to take off my streamer because I have a hearing issue there and I can't do that. So try to catch, so then you try to take a step forward with your pelvis rotated to the right. I just changed my microphone so I can hear. So now, if I stand up and I pull my shirt on a diagonal bias toward the left ASIS so that it's pulling from my right shoulder, that limits the chest rotation to the right. And then, so now my midline is off to the left and I have left-sided neglect. And now in that position with my shoulders forward, my hip back, I can't do a pelvic tilt. This bias is something when I'm teaching the parents too, what their challenges their children are going through, we have them feel that, and then we see that now when we turn forward and we have the rotation to turn forward, and then we can take an easier step and catch the ball. How do we do this with telehealth? Is I take the typical transitions and I go check, 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 and I see which side is easy, which side is hard.
And this is just a sampler of what I would have with a infant. And then we circle what the child can do. So in this case, the child could roll easily with their right arm reaching across the body and create a rolling game to use to expand on what they can do. So the issue is the child can't roll. If the child's chest does not rotate to the right, their mid-range is off to the left because the shirt is pulled in this
Suzanne,
diagonal. The child can learn a rolling game to roll to the left, but they're blocked from being able to roll to the right. And so we do
Suzanne,
a Google observation to see where they're blocked. We find the missing pieces that are throwing them out of where they can't build on their control. And so a typical assessment takes me an average of 2 to 3 minutes, and I go boom, 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 and I see where they're tight.
Suzanne,
And
we can't hear you.
And then we address it. Let's think about these blocks. Here we have the boy at the top. He had hardly any active mobility. He was all bound up with his blocks. He has a severe tone issue. We're not going to change the tone any more than we're going to change his eye color. That is part of him. That's who he is. But he has so many blocks. We remove the blocks and we get access to some mobility that the child can use.
Suzanne,
We find Lucian, who had
Suzanne, we
blocks,
can't hear you well.
also had things that were tight from stabilization. He was holding his arm, his scapulas pulled back into, excuse me, like a high guard position so that he didn't pitch forward. He got adaptive shortening in his scapulas because it wasn't a high tone. It was that he had low tone and he didn't want to fall forward. Okay, and so we remove the blocks, we remove the stabilization by giving him the mobility, and then whoops, and then we gain the range of motion, and now he still has a tone problem, but now he can function. This little girl that had diplegia also had the difficulty with her arm. She was blocking, holding, and stabilizing that. And here she is several months later on the stairs. Oh, just a minute, please. Mona, everything okay? Mona?
Your voice is very low.
My voice is low. Okay.
Asha is saying, but I think you are not able to hear her.
I'll bring the computer closer. I'm sorry. I'll talk louder too. Thank you. Okay. So anyhow, you can see that we get rid of the blocks. We still have a tone problem, and now we can work with what's within normal limits. What is the science behind TMR? We have several publications by osteopaths that have discussed positional release. Positional release is shortening in order to gain the range. And so we don't stretch, we shorten, which improves the mobility. So try this. You put your fingertips on your sternum and turn to one side and turn the other. Imagine you were going to do a yoga pose. This is how I do my yoga. You go one way and it feels good, and the other way may have a block. It may be stiff. With our children with CP, this block is a hard infield or bind. It's like tape. They cannot go here. It's represented by, if you take your shirt and you hold your shirt down by your left ASIS and you're blocked, I can't turn to the right, I can turn to the left. And so how do we treat them? We turn into the range that is what we call the yummy range to loosen that and improves the mobility. We have many theories on how this works that's in science, and in the book on Manual on Counterstrain, Dr. Van Buskirk talks about the hypotheses that you're clearing the wastes, you're inactivating the pain input, quieting reflexes, etc. Excuse me. Is it loud enough? Yeah. Can you hear okay? Yeah.
Yeah, people are not able to hear you properly. Can you repeat the last few minutes again and little loudly?
Okay. Yes. Go back.
I'm sorry to interrupt you.
No, that's okay. I want to make sure you can hear me. How far back do we want to go, Mona?
Maybe 5 slides back.
Um,
Last 4 slides, 4, 5 slides back.
okay.
Check the message. Yeah.
Here? Okay. So, okay. I'll try here. So, once again, I'm sorry you couldn't hear me. The rest, my family is sleeping, so I wasn't being loud enough. I'll get closer. If we look at the child and we see what they can't do, they can't rotate their shoulders to the left, to the right to roll. If you take your shirt and you pull your shirt down from your right shoulder to the left ASIS, it pulls on the bind. And then you can't take your right arm to learn to roll to the right side from supine to prone. But you can easily roll the other way. If you have a piece of tape that is on your body, I don't know if you can see my doll here, but I have this tape. The doll can roll to the left and can't roll to the right because they're blocked. Okay, so this bind is limiting their mid-range. And so we match a sensory experience with what is enjoyable for them to do and make a game out of that. And when we look for the missing pieces in the mobility to gain a full range to be able to play. And it takes 2 to 3 minutes for me to identify these blocks. So in this case, you see the child can rotate their chest to the left and their pelvis to the right. And so that means that their counter rotation is easier in that direction. That's the way we have them roll. We have these 2 examples for children with neurological challenges. The one on the top, we saw him. He had no ability to really do anything with his body, with using any mobility, because he was bound up with the blocks. We removed the blocks, and then he can now use the mobility in his hands. We're not going to change his tone. His tone is part of his makeup, but we can give him more mobility to be able to do something pleasurable. Lucian and my friend Sorel here were stabilizing to hold themselves up and had adaptive shortening in addition to the blocks in the rotation, the flexion, the side bending. And so when we removed those with the TMR, then we had the achievement that you see. The science behind TMR has been published, and Dr. Chetow in the positional release manual was kind enough to share with me this picture, but what I put on here was a silly putty in the tape. The tape is to replicate the end range. Perhaps you go 20 degrees to the right when your shirt is pulled, and you can go 40 degrees to the left. And when you hit a bind when you go to the end of the range on the hard side, but the easy side, the motion that's comfortable, you can hold it there and go further like silly putty. These are theories of how the shortening works, clearing the wastes. The most information, just this week I attended a webinar, and Dr. Shah at the National Institute of Health is doing research on what's happening in the tissues with stasis, with prolonged shortening to help get elongation. The most common counter-rotation pattern for our children is to have what we call left upper twist, right lower twist. So if you stand in that position with your chest to the left and your belly to the right, okay, about 60% of adults are in this pattern, but most of our children are in this pattern. And that is the pull from the shirt from the right shoulder to the left hip. The opposite counter rotation pattern is less common. And I represent that with a soda pop can that is twisted and then taped on the diagonal, the same as the doll. So you can feel which is your preferred twist side by putting your fingers at the bottom of your sternum. Your lower rib cage is like the equator going around the globe. On women, it would be along the bottom of their bra. And then you rotate one way and you get to the end of the range and it's comfortable, you can breathe, and your tissues elongate like silly putty. And as you stay there, like you're doing a yoga pose, you're not stretching it, you're just playing there. We build that into the activities that the child can do, doing repetitions. And so that is loosening the tape. Why is immobilization a villain? Dr. Zink, that developed that common counter-rotation or common compensatory pattern model, hypothesized that it came from the constraint in the womb, that the children in the womb are rotated with their shoulders more to the left and their belly more to the right. Typically, developing children in the hours and days after birth move around just like when you get out of a long car ride and loosens you up. But the children with CP and other medical issues, which are limiting their strength, then they may get locked into that posture and be stuck forever. And so you see that you can have all kinds of problems that go along with this asymmetry that you can get back. For adults, it can go into back pain. For a short time, because I was working with babies, I was also interested in what was going on with the mothers postpartum. So I had some women's health experience. And so it's all part of it. There's a Sieben Syndrome, which a Dr. Hans Mao relates all of these pulls into various things that we see all the time. The contractures, the pelvic obliquity, these are all pulls that chain up and down the line in our children. And then we have, because I had to repeat, I'll just skip over this, but we have doctors and so forth that have explained this. So let's talk quickly about traditional stretching. Why does it not last? Because if we have a block of a pathological, which Dr. Schleip calls a pathological restriction, and we have and maybe it's like wrinkled like this blue tape here, and we do some gentle stretch, and we get a little bit of range, and they may keep that little bit of range. But if we stretch too much, that tape does not elongate anymore. It's at the expense of the micro trauma to the surrounding tissues. And we come back a week later, and where are they? Or even the next day, it rebounds and they're back a little bit longer than they may have been in the beginning where they had the wrinkle, but really not much longer. When we shorten to lengthen, we pucker that tape and we remove the tape, and the next day it might even be better than ever. With the caregiver follow through, it continues to improve, and that's how Lucian's hamstrings got longer. Okay, so we shorten, and it's like the finger trap that we squish it together, it loosens, we pull it, it tightens. What is contralateral lengthening? Contralateral lengthening is when we engage the child in doing something fun, which indirectly shortens and puckers the tape on the other side. And that's what we do with TMR. And so the fascial pulls go from head to toe, I did a separate a class for lactation consultants on how asymmetry in the legs can feed up into a feeding issue because of the pulls that go all the way up into the tongue. And I did a workshop at the International Fascia Congress on the interconnection of the tissues and hypermobility one place related to hypomobility in another. So this woman that has a pelvic tilt that's limited because she's tight on the front. So if she was a child with CP, she'd be a sacral sitter, but where is she hurting? In the kyphosis, in the upper back, because she's pulled into the flexion block. Okay, so the children with CP, one of the biggest things they have as an issue is the flexion restriction, pulling them down. And typical therapy is to try to get them to straighten up tall, to get their back strong. But if they're pulled down, they can't do that. So here's an example. When we first shorten them, doing TMR, we have more extensibility on the tissues in the front. And then we can do something like a ball game or something that will facilitate the deep postural extensors. Okay, this little boy had a severe bleed. Okay, he was a 3, 18 months to 36 months, the progress. Okay, finding the blocks that were limiting. He dragged his left leg, dragged his left arm, and you see the arm and you see the legs here. The only difference was TMR. Here he is, a little bit older, because as he grew, mother continued to follow through. I did not see him after 36 months when he aged out of early intervention. But here he is, I believe he's 8 years old here, the same child with the severe bleed. Okay, and you see that left arm. He was very, very involved, but excellent parent follow through. So she continued to work with him as he grew and building on his strengths with higher milestones. So imagine you have a goal of independent toilet transfers. And say to the parent, what do you want to do? And they want to get on the toilet. Rather than trying to practice how to get on the toilet, we identify the blocks. Where are they blocked? They can't weight shift to get to the edge of the chair to stand and pivot. And why? Because there's no elongation on the left side and it's all a struggle. We don't want them to struggle. So you take your shirt and you tuck it in on the left side and it pulls your left hip up, okay? And now if you trying to weight shift and you can't elongate your left side if your shirt is tucked in. And so you can't weight shift to move to the edge of the chair. So we remove the block by shortening the left side. And now the child can weight shift onto his left buttock. And then we make a fun game because he's not ready to stand yet. He still has to get to build up that a little bit more mobility and learn to practice the weight shift. So we make a fun game dancing, sitting in his wheelchair, going back and forth. And he says, look at me, mama. And because he can now shift back and forth where before he couldn't get his buttock down. And then the next visit, we work more on even getting more elongation and ultimately progress to pivoting without struggle. We observe, we have a child that can't sit up during dinner. Mother says, oh, after 5 minutes, he falls over in the chair. I want him to be able to sit up through dinner. Where is he blocked? Like the other one, elongation on the left side. Pre-test, if we level his shoulders out, his left ischial tuberosity is 3 inches off the chair. And the parent measures that and she puts 3 towels under the buttock. And then he isn't falling over. Post-test at the end of the session, we have, or at the end of the releases, he's now got 2 towels, 2 inches off the floor or the chair. And the functional change is the distance from the ischial tuberosity to the chair or time. He's able to sit up and eat dinner for 15 minutes now after you leave. And he has emerging ability to weight shift onto the left buttock to be able to transfer to the toilet. And so we stay in touch with the parent, and they're doing their releases and they're doing their sitting dancing game. And then the child goes closer and closer until they can finally get all the way down. Another child wants to color with pictures on a large paper, but they fall over to the left side because they're not elongating on the left side and their ribs don't rotate to the right. And so they also have left-sided neglect. So they're struggling and they're only able to play with and do the coloring to the left side. So we remove the block at the beginning of the session so the child can sit equally on both buttocks and rotate to the right. We make a fun game going back and forth, and now the activity is they can use their new range to color with a bigger range of play. We can measure how many inches to the right. They can now use their coloring on the right side because they improve range in their chest, and they can use that left arm that was neglected to hold the paper. Okay, when they don't want to go to the right, something is blocking them. And we have parents have a landmark and they can look and see they can't go, how far can they go to the left? And they can go way to the left. They don't want to go to the right. And we might measure how many degrees, improvement. First, they can go 10 degrees. After we do a release, they can go 30 degrees. The parent looks at landmarks. Oh, they were at the left of the window. Now they're the center of the window. And what do we do afterwards? They're going to do targeted rotation play and daily routines with the siblings. We find the tapes. We shorten the tapes. We see this child pre-test and post-test. What's pulling her down in the wheelchair? What's pulling her over? We release it, and now we can work on things in a more upright, comfortable position. We have the child, we identify that he can only roll to the left. We engage him with the left rolling to learn to roll as he's snuggling his teddy bear at home, because that is the direction that is going to simultaneously release his tape so that ultimately he can learn to roll to the right as well. So the 10-step protocol provides a GPS. I had a map with NDT before, and now I have a GPS because it takes things into little steps, and it also gives us a framework to work with the parents. The first step is, what's your concern? Then how can I help you? What does your child enjoy? And it might be they can't balance to catch a ball with their brother. Clinical observation, how's the function limited? How is he standing? Stands with his right hip and left shoulder retracted, falls to the left side, struggles trying to catch the ball with his arms to the left, and an uneven height, and all his weight is on one foot, like the girl that was dancing. I identify the blocks, and then we release them by doing play into the direction of ease. Then we organize, or might have him do some bouncing or wall slides or something, so we can feel the change in his mid-range. And so here we have the child engaging in the way that they want to go, not the way they can't go. And then we do the clinical observation. We note the improvement in the center of gravity, how many degrees they can turn, the improved weight bearing. And then we activate, we plan sitting ball skills perhaps. Maybe he's not ready to stand, but we design a activity based on what he wants to do that's targeted to get him to get control until he has enough alignment to be able to balance very well on both extremities with further TMR motions. We're going to work on what he's enjoying in a range of control. A dialogue with the family on how to continue to do that, how to structure the play with his brother to continue with the active motion and therapeutic positions that will simultaneously improve his mobility. And then there's a teach back and home program step where they show me how they're going to do it. They choose and they show me. We test the children. Anybody can do this. You take the child and you have them put their right elbow on their left knee, and that shows the mobility to do the rotation to the left of the chest. And then you try to put the left elbow on the right knee, and then you'll see if they're blocked in that rotation bias. We also check and feel for limited elongation left and right. There's no pain allowed. So here we're snuggling the child into into a position of ease, and he has profound hypotonia, a G-tube, and the issue was he can't breathe well, and his breathing was erratic, and he's got no head control. So here we have, he can't hold his head up. Why can't he hold his head up? Because he's pulled down in the front. I try to facilitate back extension to have him look up at mommy, and he can't look up at mommy because he's in such a kyphotic position. We snuggled him in that release position, which was to bring him into the position of comfort. And then we did a little horsey ride, giddy up, giddy up, giddy up on my knee, so he could feel the new alignment. Post-test, he can straighten his back more now. We can target facilitation opposite where we removed the block. Then we can also give him the hold him up in his new posture and have him look at mommy and work on graded head control. So if we can't support the contralateral side, if he didn't have the strength in his back now to use his new ability to access, to facilitate his deep postural muscles, we might use some supports to give him, to help him have the alignment in order to participate without struggle until he can gain that range. This young lady had never been on her side. She was so side bent, she could never be on her side. She still has some block on the right side, but we got enough elongation that we could put her in a position to use her new length. And now, for the first time in her life, on her left side, she can take her right arm and reach out and started to play with things with her right arm and sideline because we first got rid of that block on her side. So we teach them what they can enjoy. We release and we go to the opposite side. This is my husband, just to model. See, imagine that he's got a tightness on the left side, pulling him down, and then we have to facilitate, then we can facilitate, do targeted facilitation where he was over lengthened, okay? So the center of gravity is pulled forward in the kids with CP. Sorrel at 28 months had been getting traditional therapy since newborn with CP. They thought that her CP was affecting her upper extremity as well because she was not using her right forearm. She was actually stabilizing to hold herself up by locking her right forearm into pronation and holding it there. She was stuck in flexion. She was stuck in a twist. I worked with her motions, and a month later, she had supination in her forearm, because if you take your arms and you put them out in front of you and you rotate to the left, your right forearm will indirectly go into pronation. So doing a dance like this is treating the tight pronators to loosen them. It's doing a indirect positional release. And so I went out to see her, and mother says she can use her hand now a month later, after 4 visits of doing TMR to help her stand up taller. Now she can feed herself. And 6 months later, she was independent on the stairs. Okay, and here we look for the pulls. Okay, and the pulling down was what was limiting her. And here she is. So at 28 months, she couldn't stand. Now she doesn't even need AFOs or special shoes. Okay, she went to a 1. Carson was a shaken baby. He had a severe pelvic obliquity. We targeted the release on the block that was causing the pelvic obliquity. And here he is post-release of just the one block that we identified. You see where his headrest is. He is no longer in the correct position because he is in better position. And he's no longer windswept. Before that, he was in a severe windswept position. Okay, this gentleman, you see here, was 23 years old. So I said I work with older folks too, on the cusp of not being able to walk. His right hip is retracted. Oh, his you see his hip is retracted. He's side bending. He was in pain. He had these knee cages on. He couldn't weight shift equally left and right. See, now I'm testing the elongation left and right, and he's not elongating on his right side. So we go test, 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 and then we go release. 6 months later, no knee braces, less kyphosis. What was pulling him down, we're seeing he can now extend his back. He's still somewhat side bent to the right, and he's still a little tight pulling himself forward. I'm showing the therapist how he can move. Okay, and so I'm assessing his side bend here. His home program is to play with his iPad. And I'm just showing how you can go deeper into ease to further release things by using his iPad. He also has a pelvic obliquity. So we're loosening that up. Okay. And then we bounce to organize and help him feel the improvement in his pelvic alignment and the change. And does he look unhappy? Okay. And then the most beautiful thing is then 1 year after the initial demo, no more knee braces. He now has a job at the gym checking for towels in the lockers and stuff. He has a significant cognitive issue. He has a cochlear implant. He's got a lot of challenges, but here he looks like a different gentleman. Okay. Now this is his whole progression. So the evolution from posture to from getting the alignment to motor control is with the improved sensory input. This young lady was unable to get up out of the wheelchair by herself. After we did the releases, we had her doing wall slides and things. She was having fun going up and down to feel where her new alignment was in space. After we worked with her, she could then get up independently out of the wheelchair without struggling. A year later, I visited her, and you see she's now standing independently where previously she was leaning against the wall and needed help to be held up. Now she's showing me how she can, she works out and plays at the gym with the ball to work on her balance. This trash can was used when she was smaller just to get her upright. We put her in the can with pillows to restrict her degrees of freedom to work segmentally, superior to inferior, so she could develop motor control, and remove the pillows as her control improved step by step while she was playing upright in the trash can. But I wanted to see, I said, can I take a picture of your trash can? And she said, I'll show you how I used to play with it when I was little. And here, a year later, she from 2 years from not being able to get out of the wheelchair, needing to be held up, and you see the right arm, she's not using her right arm either to hold herself. Her CP was also involving all her extremities, but she built up the strength working at the gym, playing with the ball. Everything was targeted based on TMR. What was she unblocking and what was she then could work on herself? And here she is hiking. Okay, so we have this, the objective of the course is to gain the foundation. And then we organize, we give additional information, sensory information is a big part of it. And we do targeted eccentric facilitation, etc. But that's all the second part of TMR. I am done with this presentation. And
Thank you so much, Susan. There are some questions.
Mona, I just finished the slides. Hello, Mona. I just finished the slides because we got a late start with those. So I'm available if there are any questions.
Yeah, I'll be talking about the questions.
Start. Okay, let me find this.
I'll just tell you the question, Susan. Can you hear me? Okay, Susan, I have a couple of questions. Can you hear me?
Chat. Okay.
Suzanne, can you hear me? There are a couple of questions for you.
Couldn't hear.
Can I just say some, Susan?
It's not in the chat box.
There is in the chat box. Suzanne, can I just speak to you?
You showed few examples where you showed that the GMFCS level changed from 3 to 1.
Yes.
The question is, rather than changing GMFC level and deteriorating the function, isn't it that we maintain the GMFCS level and improve the function? That is the question. And that be checkbox. You can answer that. And just talk to Asha because
Suzanne, can you hear me, please?
Yeah, okay. Okay. Mona was calling me to tell me there was a question in the chat box.
There are a couple of questions. I'll just tell you what the
Yes.
question is.
Yeah, the only question in the chat box.
No,
is
I have some
she could not
questions,
hear me.
Suzanne.
I'm sorry, I could not hear. I have a chat box and it just says we can't hear you much.
No, I'm going to speak to you. Can I just say some questions, Suzanne? I'll speak to you. Can you hear me, Suzanne? We can't hear you, Suzanne. Mona, we can't hear her at all. I have some 4 questions. I don't know who's, yeah, Mona, I can't hear. Yeah, but I don't know what, 1 minute. Suzanne, can you hear me, please? Yes, Narasimhan. Yeah, but she's not listening. Yeah, but she can't listen, I guess. Suzanne, can you hear me, please? Suzanne? Okay, I can't hear you either, Suzanne. Mona, can you give me her number? તમને નંબર આપને તો હું ફોન કરું, એને સંભળાતું જ નથી મારી વાત. કરી દીધું મેં પણ એ વાંચતા જ નથી. મેં એના ચેટમાં છે. તું મને નંબર આપને તો હું ફોન કરું. કૌશલ શું કરવાનું હવે આપણે? I think so. We have gone ahead, and there is some technical hitch, and I don't think so Suzanne can hear me. I guess what we've understood from her, and if I have to sum up, that this is kind of a preparatory strategy that she's explained. She said to kind of release and organize and activate. I know that there were questions from Sanket about changing the GMFCS levels. Of what I know, you can't change GMFCS levels. Sanket, that is all that I can tell you. I do not know her thought process that she's explaining. One second, one second. I'll just see the chat, what she's. Okay, so I'm not sure. So she says, I do not make goals for children. The children and family decide what they want to try to achieve and guide. That's her answer to you, Sanket. But I think so if I have to just conclude this session, we need to look at children on the ICF classification, specifically with children with cerebral palsy, is a must, absolutely a must. And I guess whatever you do, you need to change their participation. So be very realistic of what you look at. Thank you so much. Thank you, guys. And thank you, Narsimhan and Kaushal, for helping me always. Bye-bye. Thank you.